Welcome to the COVID-19 Learning Series for Long-Term Care. I'm Sarah Metcalf, a Program Manager in Long-Term Care and the moderator for this session. Just a reminder that this session is being recorded and will be posted on the COVID-19 intranet page for people to access later on. This is also where you can find all the recordings from previous learning sessions if you haven't had a chance to look at those. First of all, I would like to acknowledge today that I am a visitor working on the traditional territory of the Lekwungen-speaking people, known as the Saanich, Songhees, and Esquimalt peoples. Please take a moment to reflect and acknowledge the land that you are joining us from today. Thank you for taking the time to join this learning series. The purpose of this series is to build your confidence and help you feel better prepared to work safely during a COVID-19 outbreak. Our first 3 sessions covered what to do in the event of an influenza outbreak. The second was how to prepare and contain a COVID-19 outbreak on site. And the third was the response protocol for a COVID-19 outbreak. We would really like to get your feedback on today's session as well, so I'll be posting a link to a short survey in the chat box once we get started. If you can just copy the link into a Word document or something so that you can still access the link once the session is over, that would be great. Today is our 4th session in our 5-week series, and it's about visiting in long-term care. I know this is something that has been coming up a lot at the sites with lots of questions from families. So I think it'll be really helpful to review the current guidelines and some scenarios for approving visitors. I'd like to welcome our guest panelists today, Katrin Brody, Lisa Young, Ben Shaw, Carmela Vetza, Lisa Diamond, Karen Carnes, Maggie Schultz, and Marlene Montgomery. Thank you so much for joining us. We also have Bhavin Manhas joining us today, and she will be starting us off with a brief overview of the visiting guidelines. Bhavin?
Thanks, Sarah. Okay, so I'm going to share my screen here just so I can show you. If I can just get a few thumbs up to make sure my screen is in fact being shared. Awesome. Okay, so not going to speak too in depth about the guidance and the guidelines, etc. I think that's what the panel is going to review a bit more in detail. So if you're on the Island Health intranet and you can easily access it, this is how you would find the most recent and up-to-date guidelines. So clicking on the COVID-19, you want to go down to long-term care. I'm sure you've all done this many times before. So this is where all our guidelines live, and we've tried to couple in all our visitor guidelines in here, with the exception of our essential health visits. I think that's been a topic that's not been as riddled with confusion and challenges, but to make you aware of that guideline. So the purpose of this guideline, we created it because we recognize there is a number of different healthcare providers outside of direct care teams in long-term care that were visiting with the resident, whether that be in the facility or outside of the facility. And so the purpose of this guideline was really to outline how does a team, a healthcare team, make the decision about what is considered an essential health visit. I know there's been a lot of conversation about what is considered an essential visitor, but that language and decision making also needs to be applied in the healthcare field. So when it comes to chiropractors, registered massage therapists, one of the pieces that was brought to the table during the pandemic was around dental hygiene and dentists and dental professionals. So this guideline is meant for all our long-term care operators to provide you with some guidance around what are the parameters in making a decision about what is an essential health visit. The other piece of the guideline in here also goes through, once you've established someone is an essential health visitor, whether that be in or outside of the facility, the next step would be really important to make a safety plan that makes sense for the resident and the health provider. And Just a reminder, if you could mute if you're not speaking, just because I think there's some background noise. And I think that might be you, Maggie, is it? I'm going to mute you.
Just muted myself, sorry.
Oh, perfect. Okay, and so this part of the guideline goes through some details of what we would expect is the bare minimum in terms of the safety plan. So that gives you more details, and also there is a piece on some of the guidance when it comes to if there's going to be transportation involved in the health visiting. So that is the summary of the essential health visit guideline, and that falls under the clinical care. The other two guidelines, of course, when it comes to visiting, there is two types of visitors that we're allowing. One, it started off with essential visitors, and then there was the social visiting. So we've got two guidelines, and one, again, Marlene was instrumental in bringing this one together. This, again, is a supportive document that helps with the decision-making that is left to the operators to work with their residents and families to determine what is considered an essential visit. I think that was the source of a lot of stress at the outside of the visiting restrictions and opening it up. So this was our attempt at trying to take the language and clarify and give some supportive guidance to operators. So I'm not going to go through all of it, but it goes through the principles here. And again, when it comes to the definition is outlined as per the ministry. And the ministry does set out the details about these visiting parameters, but our job as the health authority was to look at the language and see how can we ensure the interpretation is allowing for essential visits to happen and for people to feel comfortable in determining what is an essential visit. So Marlene very cleverly worked to create some different criteria and examples for the type of essential visits that are outlined, such as compassionate care, assistance with feeding. So what might that look like? We're not just looking at anyone that needs help. It's the fact that that family member or loved one would be someone that would enable that resident to receive a visit that helps with improving their intake. If they're showing signs of dehydration or weight loss, or if they're finding that they're not as interested or apathetic about food, it might be an indication that the team needs to look at supporting essential visits. So this guideline goes through in detail some of the questions that the care team can ask in determining whether someone is an essential visit. And the last guideline is for, oops, I've gone backwards. The last guideline here is about social visiting. So as you know, the ministry has put out that each resident is able to have a designated social visitor. And so we've just recently updated this guideline as well. And so it will go through around, again, what are the principles around social visiting? How should the decision be made of who is a social visitor? I think one of the pieces we've recently clarified is the need for the operator to be able to support a change in the designated visitor. For example, if a loved one is going to be, a designated visitor is going to be out of the country for 3 weeks. During that 3 weeks, could there be another family member or loved one or representative that could be that designated visitor? And the answer would be yes, and the facility should work with the family and the resident in order to facilitate that happening. We also go through in here in terms of, again, what is the safety plan and what are the details that an operator would need to consider in ensuring that the social visiting occurs, both with operational considerations, but also that the plan is very clearly laid out to the family. And we did add in, because of the number of questions around gifts, pets, where should the visiting occur when it comes to social visiting, that is also outlined in this guideline. And again, it breaks down prior to the visit, what should somebody consider during the visit, and then post-visitor considerations as well. The one other piece that the social visiting piece outlines is because at the direction of our medical health officer on the island, we do require all residents who've just recently been admitted to facility to undergo a precautionary 14-day isolation. And for persons who are having respite care, they do have the ability to have social visiting occur. And this section outlines some of the considerations in making that decision and supporting social visiting there. So I will mute my mic now and turn it over to the panelists.
Great, thanks so much, Bevan, for that. Yeah, so our panelists, you guys can go ahead and unmute yourselves. I'm just going to share my screen here so you can see what questions we're going to be going over. And just give me a thumbs up if you can see it okay. Excellent. All right, so our first scenario, Bevan kind of touched on a little bit already. It's about changing a resident's designated social visitor. So the scenario is, can Mr. Smith change his designated visitor? So Mr. Smith's son was appointed his designated social visitor. He has been visiting his father at the scheduled times for several weeks and is now asking to change the designated social visitor to another family member. So our first question is, can Mr. Smith's son request a change to the designated social visitor, and under what circumstances would this be permitted? Who would like to tackle that on our panel?
I'll go. I'll jump in. It's Carmela. So the short answer is yes. We can change designated social visitors. There was a time that that was not as clear, but we can. It is absolutely true that some of our social visitors, either they themselves get ill, they have to move, all kinds of things can happen to that social visitor who can no longer continue visiting. So absolutely, another designated social visitor can be appointed. The spirit of this order and legislation, or the order, is to really ensure that there's a minimum amount of people coming in and out of the facilities. So as long as we're not changing the designated visitor every week, every 2 weeks, just to afford a resident multiple social visitors, then absolutely we can use that common sense to be able to say, yes, in this instance, this is about the social visitor can no longer visit for a period of time, therefore we're naming another visitor.
Great. Anybody else have something to add to that?
I think it's Lisa, and I think as one of the managers here at the site, that the requests to come in frequently for changeover from families, and that the families are looking at it as an opportunity for everybody to see their loved one, and they're wanting to rotate through so that the family member has that, and it is challenging, and they also talk about burnout, and so trying to provide equity to the family members, trying to provide equity to all families, not just the family members within that one, to be able to see what we can do. But I do know that there are some people who are quite elderly and they find it quite a burden to be there and be the only one. And I think that, having that consistent criteria, not swapping them out every week, but we definitely at the summit have had to look at, when it is appropriate to make that switch out and analyze that, and then let them know that if they're switching out, it doesn't mean that they get to come back, in 2 weeks from now when they've had a rest. And it's like we kind of have that discussion, and it goes over well with families if you kind of work through the details of that. And so I've appreciated some of the flexibility around allowing family members who are burning out or who are going out of town for an extended period of time to work away a month and here a month, how they can navigate that.
Absolutely. Yeah, so I guess it's up for a conversation, and it's definitely possible. It's just need to work out the details, is what it sounds like. And so I guess we kind of talked about this. Can they alternate between family members if they request to? Is there any sort of specific time frame where that should occur, you know, where they can alternate every 2 weeks, every month? What are your thoughts?
Again, I think we have to be thinking in terms of the spirit of what the order is. And the order is about trying to protect and limit the numbers of people that are coming in and the number of possible transmission sites, right? So, or transmission points. So, you know, Lisa brings up a really good point in terms of, you know, is this a way for families to be able to get multiple family members to be able to visit? And, you know, I totally get it, because as a family member myself, I would want to try to do whatever I could creatively to be able to make it work for everyone. But the reality is we are responsible for ensuring safety, and following the order is what we have to do. So this is where we get into the gray zone, because is it every 2 weeks? Is it going to be, well, you know, Mrs. So-and-so has to go off for surgery, or is going to be off for a few weeks, so wants, you know, someone else to come and take her place, and then we'll be back. Is that something we can negotiate? Is it a fairly, you know, substantial period of time, 2-3 weeks? Yes. I think it's understanding the context, and this is where it gets really difficult for the operators of the site, because you also have to be really clear that we're not being arbitrary. We cannot be seen to sort of saying, well, we like Mrs. Jones, so Mrs. Jones can come in, but we don't like Mr. Smith, so there's no way he's coming in. It can't be arbitrary at all. At the same time, no two situations are necessarily identical. And there will be context that we have to be able to look at to sort of say, does this situation still fit with the spirit of the order in terms of limiting transmission rates? Does this make sense within that context? Again, we end up having to use some judgment. And again, our judgment is going to be questioned, and we have to be able to demonstrate that we've actually had a thought process for why we've made that decision. At the same time, ensuring that we're also flexible in being able to respond to the various needs, and keeping our resident focus in terms of their needs. It is not easy when we think about visiting, whether it be social or essential.
One of the things I had a good conversation with a couple of families is talking about fairness. And I said, fairness is not about treating everybody the same. It's about meeting everybody's needs the way that resident needs it. And actually that really resonated with the family, and that, you know, to talk about fairness, about looking at individual needs and meeting their needs versus applying the same broad stroke across the board. And so I think that when we're looking about this, we are really looking at fairness about needs, not necessarily about the same approach to every person.
Absolutely. All right. I think we can move on to scenario number 2. So in this scenario, it's about essential visiting. So Mrs. Jones is a 92-year-old with dementia and a long-standing history of anxiety issues, among other medical conditions. Prior to moving into long-term care, she lived with her daughter, who started visiting her daily once she was in long-term care. During these visits, she helped with personal care, encouraging her mother to eat, and taking her for walks outside and for outings. Since COVID-19 started, Mrs. Jones's daughter has been asking to be an essential visitor to continue with this level of involvement. She feels the few designated social visits they are permitted are distressing to the resident, and they often end with them being upset and frustrated. So the first question is, should Mrs. Jones's daughter be an essential visitor?
Maybe I'll
I'm
jump
gonna
in.
jump into this one. Sorry,
go for
Katrin.
No, go for it, Marlene, because I know this is your scenario.
Yeah, so this is one of the ones, although we created criteria, you know, you're sort of in two situations. You've created some criteria because yes, we want to have some clinical thought around these decisions. However, not everything is a clinical decision, and one of the things that we haven't been able to really define is compassion as well. And this was one that we looked at really carefully, and actually this person was not granted essential visiting status because the mom had not lost weight and had any increased PPD scores. So, and this is one that is what, like as Carmela talked about, this is one really in the gray zone because both family members really wanted this. The daughter did do a substantial amount of care before the mom came in. And when she came into long-term care, she was there every day. And so this was a big change for them. And not every family member comes in every day to look after their family. So this was one that was very gray, and we had to agree to disagree on this one. But I'm just really curious about what other folks think about this scenario and how you would interpret this, given. Would you think that this is an essential visitor or would you not?
Yes. So it's Katrin. One of the things that I use when I'm trying to understand is someone an essential visitor is quite often the family was what I call a partner in care. You know, they were someone who was very involved as a partner in care to look after that person who's now in long-term care. And to me, if that person was always that involved person, to me, that, in my opinion, that is still essential. It's different from a social visitor who's maybe going in just to say hello and, have that little visitation and having that great, time, I love you, grandma. But if they were always that partner in care, to me, I don't understand why we wouldn't allow that person to be essential, in my opinion. But like Marlene said, everyone interprets it slightly differently, and the operator in this case did not interpret it that way and felt the person wasn't essential.
It's Lisa. I also think from my standpoint that we can't underestimate the clinical impact of somebody helping somebody eat or taking for walks. That is social emotional component. And if the resident was appearing to be distressed and sad or whatever from the lack of that support, I think that social emotional piece is covered in the essential visitor component. I do think though that every essential visitor needs to have a structured plan as to what that essential visit is when they're, like it's not just a free for all, you can come in and do whatever. Your essential visit is for a purpose, and that needs to be outlined, and you need to stick within that structure of what that essential visit is for, and it needs to be reviewed on a routine basis to ensure that that need is still a need that's there, and that is it being met or is it not being met, because I think that's part of the clinical process is to see, does that happen? And I think that's how we can look at fairness, and I'm not saying equity, but fairness across the board, right? When we have to start to, as an operator, look at, are we, is it an arbitrary decision, or is it one that we can stand behind, right? I think that these things aren't always necessarily essential forever. I mean, maybe there's a settling in period, or maybe it does need to be for, an extended period of time. What my concern is sometimes, we don't take these as essential visits, and then mom has lost, significant weight and muscle mass and, different stuff because she hasn't moved, and they actually can't regain that at this stage and age. And so we've actually done them a disservice by not allowing these essential visitors in to provide some of these things that on the surface may appear like fluff, but actually are really helping to maintain the quality of life for that person and also their physical health. I would have let this person in. Potentially, I would want to talk to them a bit more personally, but
So I love those comments, Lisa, and especially when it comes to equity, because that's a sort of one of the things that the operator was really worried about. And they were worried, if I let this person in, who, then I'll have to let everybody in, was the thought, right? But I think one of the things that makes it really hard to determine too is that people with dementia and that sort of disease process, it's difficult to tell when depression actually is happening, and what is happening with them from a psychosocial aspect as well. So yeah, it's good comments about equity, and I also really love that make plans for these essential visitors that have criteria about when they can come in, what they can do, and there is a time to review it. I think that is something that would make many site managers feel better about it.
I know Maggie's on the panel as well, and I'm sure, Maggie, you've got some thoughts, because you certainly were, essential to your partner when he was in long-term care, and so I'd be curious about your thoughts. But also, Maggie sent out some interesting document last week that also touches on what Catherine said about the family caregiver often being our partner in care. And it's how we envision or how we see that essential visit. And if we see that essential visit as the partner in care, it then makes sense to have a plan as they become part of the care plan. And then you've got a plan for what that visit is, the purpose of that visit is.
Okay, my turn now. It's Maggie. I'm really very favorably impressed with what you're saying, especially with Lisa and the plan aspect, because most people don't seek to be an essential visitor for frivolous reasons. It's a terrible thing to, as in the case of my husband, who did develop quite severe dementia, to see him confused and suffering and anxious when he saw me leaving, and when was I coming back. And so, yeah, Carmela's right. It was a very difficult, but also daily thing that I did, no matter what. I'd be looking, when I look at the Jones scenario, I look at the sort of some key words. Living. Mrs. Jones was living with her daughter. She wasn't just being visited by her daughter. She was actually living in her home with her. And as she would have been deteriorating mentally, her daughter would have been a constant in her life. So we put her into care. That constant is gone. Sort of comes in and out on a quasi-social basis. And I just see that as being so unsatisfactory. And the aspect about, oh, gee, she hasn't lost any weight. Well, so what? That doesn't mean that she isn't in acute mental and emotional distress. So things I'd be looking at here would be just very much what Lisa is saying is, okay, let's make a plan, daughter. How be you come in for 2 hours, 3 times a week. You do these things with your mom. You come in at lunchtime, and or you come in at supper time, but have a structured thing so that, yes, daughter is part of the team, feels part of the team, and also gives some continuity in mother's life. And I think with people with dementia, that's so important. I mean, it's like you guys are the professionals, but I'm on the ground. And I'm walking through this experience with a lot of people who are friends and neighbors. And this is a common experience with them, especially when their loved one is demented. Anyway, my comments for what they're worth. I'd be letting her in.
Yes, Catherine, you had a point?
Yeah, thanks. Thank you, Maggie. And I also would just like to to add on a little bit about what Lisa said, I really like that idea of having a really clear plan and maybe incorporating to the care plan, because I think that will also be really helpful when someone transfers from one long-term care home to another long-term care home, which happens all the time. And we know that different operators do interpret these guidelines differently. So if someone is being transferred, they have the care plan that goes with them that shows very clearly why the person is essential and is part of the care plan. I think that will also really help the receiving long-term care home. And then it will hopefully stop those scenarios where families are really upset when they were essential at one care home and then their family members moved and now they're told they're not essential. And then guess what? Marlene and I have PCQOs that we have to deal with, patient care quality office concerns, lots of them. Thanks.
And Marlene, did you have something to add as well, or no, you're good? Okay. So the second question was, would it make a difference if the daughter was not helping with personal care or feeding? What I've kind of heard from that conversation is it could, but if there were other areas that could potentially be put into some sort of plan for the resident that was going to be beneficial for them, then perhaps they could still be an essential visitor. Am I hearing that correctly?
Yes.
Great. And if the staff feel that Mrs. Jones is no worse off than other residents, and you know, it's all the residents are having a hard time right now, not seeing their families, and Mrs. Jones is one of those residents, and the staff are concerned that letting one family be essential will sort of cause a snowball effect. Like Marlene was saying, in this scenario, the facility was concerned about you know, making an exception for one family and then having other families ask for the same thing. How can we address those kinds of concerns to show that, you know, due diligence is happening when we make these decisions?
I think that it's interesting language where you say we're going to make an exception for Mrs. Jones, because quite honestly, I don't think this is about making an exception for Mrs. Jones. It's around using the criteria that we have to figure out a way that we can say yes safely to families coming in and being care partners and joining the team in ways that are organized, and we have to have them organized. We have to have, I don't know, control, quote unquote, but we have to understand what they're doing and have them be a care partner without, you know, like saying, okay, we'll make an exception and let you in. I think that we're doing our residents and families and ourselves a disservice. We have to be able to apply all the COVID precautions, but we also don't, our goal is not to prevent residents from having the enjoyment of having familiar people and people that can help provide some quality of life to them. I think that there's definitely residents who actually benefit from not seeing their families, and they say so. And you know what? This has actually been a help to them. And so we're not going to drag them in, right? But I think that there are some residents, you know, that when we look about fairness based on needs versus fairness based on painting everybody with the same brush, then it's really around looking at individual residents, you know, patient-centered care, resident-centered care, and looking at that team and saying, what does this person need and how do we make that happen within the confines of what we have? And therefore, I don't see this as an exception. I see that, you know, and it doesn't create a snowball effect if you actually can apply the guidelines in a way and integrate it into plans and make sure that everybody understands what their roles are, and that you can, you know, ensure that there's not more people in your building than you have. And if you have a plan for everybody and you're looking at it on a great map, you can see who you have here and who you don't have here. I think we can make it safe and not put anybody more at risk, but actually add benefit to our residents' lives.
Yeah. One of the things that was really interesting to me is when we got together as the visitors, sort of stakeholders. You guys tell me what, I can't remember the name of the group, but we all looked at them and went through the guidelines to see what we needed to change. And it was really insightful to me to find out that when we looked at the guidelines with an attitude of how can we make these guidelines fit, we could fit every person into these guidelines and do it safely. So it's really that gray area. Are we looking at these guidelines with the sort of focus of how do we keep people out? Or do we look at these guidelines in how can we fit people in and how can we do it safely? Because we've taken a lot of time to put in the safety measures as well, and not just these, not just the guidelines, but how do we move people in and through in a safe way? And we have provided PPE, we have provided all of those guidelines to help people move in through safely. And I just hope that we get, I think that there's been a lot of fear about letting people in, but I'm really hoping that we can have a look at these with the vision of how do we let people in.
Thank you.
Absolutely.
Yeah.
All right, I'm going to move on to our third scenario, which is around the holidays. That's something that's coming up pretty quick here, and I'm sure people are getting a lot of questions about this right now. So I'm just going to read out all the questions, and then we can just have a general discussion about visiting during the holidays. So how can sites accommodate additional requests for visiting during the holidays? Is there a way families can take a resident out of the facility temporarily and bring them back without the resident needing to isolate? So either the family isolates for 2 weeks, that's been a question that's come in, or if they only take the resident out for under the 4 hours, like the criteria for a resident going to acute care, would they still need to isolate? And what can sites do to strengthen the holiday spirit during COVID-19?
We'll jump in first on this one because we certainly raised it at our policy meeting with Dr. Fife, our medical health officer. And I was all prepared to bring these questions, particularly about the family, who was very creative about, thinking if we isolate for 2 weeks, could we take our loved one out for 24 hours? And then when we bring them back, they would not need to isolate. And also about the under 4 hours. And Dr. Fife's response at this point was, right now, the provincial health officer is telling people not to have people in your home that you do not live with. So it's very hard for us then to turn around and say, yes, you can, no, you can't, because we can't go against this sort of order and or recommendations from the provincial health officer. So that's where that was left yesterday. Maggie, you were also in that meeting, as was Catherine. Was that your take as well?
Absolutely. I mean, there was no doubt Dr. Fife was very definite in what he said, and it was exactly what you've said. I'm afraid. Yeah.
There's also the other issue that we have in long-term care, and I know, Lisa, you talked about fairness, and I agree with you. Fairness isn't always that everybody gets 1 cup of beans. It may be that the people that need the beans get the beans. So, that's how we need to sort of look at things, and I do agree. But in long-term care, we have a structural inequity, and that some of our residents are in private rooms. And so if they were to leave the building and go out for 24 hours and come back in, they can isolate with no impact to anyone else. However, if you are in a shared room and you go out for 24 hours, you now are impacting the other people in your room. So, if Dr. Fife had said, yes, that's okay, they can go out, but they're going to have to isolate, then we would be saying, well, yeah, only people who are in private rooms can do that. I think how we would end up having to do that is to be able to say, does it actually work for us to be able to isolate that person? And if not, does that mean that the person can't come back for a longer period of time? I don't know. We didn't get to that part of the conversation with Dr. Fife because he was fairly clear that we needed to follow the order. Catherine, you got a comment on that?
Yeah, just to be, the devil's advocate, as I like to be. I think this is great. The problem is we do have many residents who live in long-term care who are capable, and we can't jail them in, and they are sometimes non-compliant with a lot of our rules and regulations. And we know already folks are going out and going to their folks' homes and coming back. So that's where it becomes a little problematic, when some families can see folks leaving, and jumping in a car and a taxi or heading off, and we tell them, no, you're not allowed to do that. So I think that's where it sometimes gets into a little bit of a problematic situation.
And you're absolutely right. That is exactly the scenarios that the operators on, in many of our sites are dealing with. And we are not prisons, and we cannot lock people up, and there is no quarantine order, and we don't have a toolkit that actually, when push comes to shove, prevent people from doing what they're going to do. What we can't do at this moment in time is say to that family, yes, it's okay if you isolate for 2 weeks. Yes, it's okay if you take your person out for 4 hours, because right now the order says that you cannot have people in your household, other than the people that live with. So, we've got some restraints right now. Now they may be lifted on December the 7th if things we take a downturn in the number of transmissions, but we don't know that. This could be extended another 2 weeks. Right now, what the position we're in is we have to follow the order. What people are actually going to do is going to be difficult. If they make decisions like some of our non-compliant residents and go out and do those things, then what happens is we have to find ways to mitigate the risk when they come back. And so for a number of the non-compliant folk, we have done that. We're either cohorting them together on a site, or they're in permanent isolation, i.e. they cannot go into any common areas within the facility, as a way to try to mitigate that. But again, you can see how difficult it is for operators, as well as the family members who are doing, following all of the rules, to try to get their head around that.
Maggie, I see you shaking your head. Did you have something you wanted to add?
Well, I'm shaking my head because of if you take it down to the most basic level, this is a human tragedy. And I keep thinking about people that I know, for instance, who have taken, but this is a different situation. The mother is actually is almost imminently dying. So I don't think it's not a fair comparison, but thinking about people for whom this is likely their last Christmas on earth. And I'm afraid that my heart keeps going out to them, as I know all of you do, because you all care so deeply about the people that you're caring for. I know that. But I shake my head because it is just so incredibly sad, to think that, what are you going to do? You're going to wave goodbye to your mom through the window, and tomorrow they call and say, she didn't wake up. So I take it to that extreme. And that's why to me, it's just so tragic. And I get I understand about the logistics, and all of those things, just almost as well as you do, but it doesn't mean that I like it. And that's what I'm here for, is to represent community and not to represent healthcare professionals. So that's my take on it.
Yeah, Maggie, I really appreciate that. And I know that there's huge moral distress for operators and caregivers and our leadership team, because, we're in this business because we truly care for the residents. And, we do get caught in that rock and a hard place. We have to follow the guidelines and the provincial health orders, but our hearts are with you, Maggie, and with our residents. So it does cause a lot of moral distress.
Yeah, and I acknowledge that and appreciate that too.
We're just at time now. It's 2:45, but we do have quite a large panel today. So if anybody needs to sign off, please go ahead. Thank you so much for joining. I just wanted to reach out to Karen and Ben, see if you guys had anything to add. We haven't heard from you yet, so.
I just really appreciate the conversation, and I agree. These are awful decisions. I'm very much hoping that that the vaccine that we're being promised is going to help us resume our lives to some degree, especially the seniors who've had everything just ground to a halt. I'm really hoping that 2021 is going to allow us to turn some of this around.
Karen, did you have anything you wanted to add to this?
No, I just really appreciate all the comments, and my sentiments are with everyone. I mean, we're doing our best to meet the orders, and still, it is heartbreaking the position that we're in. But hope for the best next year for sure.
Yeah. And I kind of want to end on a positive note. So I'm just wondering if anybody could share anything that's been happening at any of the sites that have been sort of boosting the holiday spirit, anything that the activities department is doing, or what's going on out there to make it festive.
Well, I wonder, one of the things that I just wanted to say that I really appreciate the activity teams that are really decorating up the sites. It's been really great and festive, so cheers for them. And that one of the things that we did here to really help with the families is that we called up all the designated visitors and made sure that every resident who had somebody local had a visit on Christmas Eve, Christmas Day, or Boxing Day, so that every single person had a Christmas visit. And if they have nobody, the activity team is signed up to have a in-person one-on-one visit, so that all 320 people or whoever we have in the building at the time will have a personal Christmas visit this year by somebody that is important to them. So that's one of the ways that we tried to mitigate it this year, so that everybody will have something special as much as we can.
Boy, can you spread that news around?
It's a note, Shemaine, we've done the same here. We've sent a letter out today to have people book either the 24th, 25th, or 26th. We've doubled our capacity for visitation by bringing a few extras in, and we've tried to double the door visits for undesignated. So it is what it is. It is really hard, and we are feeling all quite depressed about it, not for the residents' sake and the families. So
good.
Well, that's great. We really appreciate all the efforts everybody's making right now. Yeah, thank you to the panel for joining the conversation today. It's been really great to have your feedback. Before we end things for today, I just want to remind everyone there is a survey about today's session. I've just put the link up here if you want to just quickly copy and save it into a Word document or something so you can complete the survey. We'd love to get your feedback on this learning series. And yeah, thanks to the panel. Thanks to Bhavin for going over the guidelines, and thanks to all of you for joining us today, and we'll have another session next week. All right, take care, everybody.
Yeah, thank you.